for the organizing committee of the conference to arrange this session. And just for clarification, when I was asked to prepare this session, I was very clear that the cases are those of pediatric glaucoma. So we'll be dealing with a pediatric glaucoma panel, the never-ending challenges to the glaucoma specialists. We have several cases, and as much as the time will permit, to go through them. The main target for these cases are glaucoma specialists and consultants with particular interest in childhood glaucoma, and the main objective is to present the expert opinions on some problematic and/or controversial issues pertaining to childhood glaucoma. We are honored to have been introduced already to our panelists, Professor Ahmed Khalil, Professor Anthony Khawaja, Dr. Suresh Santha, Professor Tara Reid, and Professor Tara Riyai, and this is your humble moderator, Nader Bayomi from Alexandria. So, let's go quickly through the first case. This child presents with cloudy cornea in the first week of life. So, we do our usual workup. We examine the child after taking a history from the care providers about the antenatal, natal, postnatal circumstances. We do an office examination, and then we consider doing an examination under general anesthesia. And our first question to our panel: do you believe that examination under anesthesia is absolutely necessary? And if you do believe that it is absolutely necessary, what is the age at which you would perform such an examination? Immediately upon presentation, or postpone till the child is X days, weeks, or months old? Just as a reminder again to the audience, the child presents with cloudy cornea in the first time of life, let's say the first few days of life. So let's start with our esteemed parents, please. Would you believe that examination under anesthesia is absolutely necessary, or you would manage just with the office examination? You won't put the child to sleep. What do you think, those relations?
So I think diagnosis is critical, and you don't need to. I wouldn't do an examination under anesthesia for diagnosis. Start off with topical anti-glaucoma medications. Of course, we do a UVM and B-scan ultrasonography to understand if there is any other posterior segment problem that we are missing. And then usually for us to get a fitness for anesthesia and for the surgery, it's about 4 weeks time. So by the time the child is around 3.5 to 4 weeks is when we get fitness because of the physiological high bilirubin that they have. So generally we do not get, at least this is our experience, so we don't, if I see the baby on day 1 or day 2, I tell them start with medications, make sure that everything else is done, and surgical date is given by about 5th week. And when they come back, at that time it's directly examination and followed by surgery. So it's not a specific EUA alone that we do before the surgery.
I agree, and observations was usually in the first month of the child was baby it's quite poor. You can examine the video, even if you can check his pressure, you can try to find some reduction, you can diet the process. You don't need to do your anesthesia at that time, and especially with the patient with special problems, so if it's not, the patient's too hard, the cornea is not very steamy, and you don't need immediate intervention, I would go with just as a patient in the clinic, and give dose,
So far, I believe we follow the same school, that examination of anesthesia is, although absolutely necessary, because the exam is lengthy and needs manipulations. However, immediately at young age, as our panelists have pointed out, there is the risk of general anesthesia. The palpebral fissure is very narrow, resulting in accurate measurement of the intraocular pressure. Corneal diameter is already so small to fit any tonometer, and the differential diagnosis from corneal dystrophy is not clear. And surgery is generally at that time has a very high rate of failure, so we would postpone, but we tend to our practice to wait a little bit more than 5 weeks. We wait for probably the second month to proceed with examination under anesthesia. So the question now to Hazem: how do you measure the intraocular pressure in such a child? The method, and by whatever means, whether at any age, office or GA, how do you measure the intraocular pressure? Which device will you use to measure the intraocular pressure in such a child? Okay. Professor Khawaja, would you choose a different method?
So
I don't manage children, but I would have thought the eye care would be great. We're talking about the palpable aperture there.
An eye care would be excellent for the situation of the patient, but would you rely on it for therapeutic decisions, whether medical or surgical? I mean, would you, let's say, would you rely on the eye care to choose, for example, to give medical treatment or to do surgery, or maybe this is important dystrophy? Would you make a therapeutic decision based on the eye care, or would you? What's the diagnostic?
I'm not sure there's anything that's better than that.
Okay, so far, okay.
I don't think Perkins is any better.
Sure. So, what do you think? Which technology would you use?
If the Perkins medication is available, I will use it. Otherwise, I can use the short different weights.
With different weights.
I give the standard. I will use short meter and then follow up. The same weights. Yes, with follow up the cornea data points for a different modality and the multiplier.
Professor Said, so would you use which thermometer?
Yes, it is my routine is the Perkins thermometer, and but the IOP readings will not play a role almost in these eyes, because this eye is probably glaucoma and the dermatitis, and I wouldn't suspect even if I might some other dystrophy, but it is not the meaning. It is apparently glaucoma space of the diameter is 11 and I would operate even if I find a 10 IOP in these eyes.
Okay, so we would agree that the Perkins is the gold standard. The issue of the
Our hands.
The available thermometers are the
We are the key people of this. No, but definitely, I mean, I think, in order because it is the routine we have used for so long years, it is satisfactory. But I totally agree that we should explore, of course. I think in Abu Rish and Yasmin, they use the eye care also recently more and more than Perkins.
I'm just saying, I remember when the eye care was first introduced, there was, generally most people were like, oh my gosh, this is nothing. What is this little thing that sticks?
But they proved its efficacy.
But I think with time, it's become clear that it's okay. And it's, you're not really trying to work out is the pressure 18 or 14 or something like that. You're trying to work out is the pressure markedly raised or not. And I don't think there's any evidence that Perkins will get you a more accurate number than an eye care anyway. So, but I'm not a pediatrics.
Excellent. Thank you.
Since you asked whether we would take a management decision based on it, I totally agree that this is congenital glaucoma, irrespective of whether the pressures are 4 or 10 or 20, you are going to operate. But then if you say that at any age, in the office or in the GA, typically we use a Perkins tonometer, but then we use more of eye care in the clinic, so you don't have to put the baby to sleep every time. And then the same question that was asked by my own colleagues, in fact including my pediatric colleagues, is eye care good enough and how can you take a management decision? When do you say this IOP is okay? Or you do the eye care and then anyway you have to take the baby up for an EUA. In fact, we did a study just to prove it to ourselves and prove it to the others that when we did the eye care measurements, in fact the statistician had no idea about what was the IOP that was normal or high and things like that. Statistical cutoff of 19 millimeters of mercury that we got, and we published that in ophthalmology. That when your eye care intraocular pressures were 19 or less, they correlated very well with Perkins and GAT. And when the eye care intraocular pressures were beyond 19, that means they were 20, 25, 30, the higher the intraocular pressure, they were very erratic. They were not correlating with your GAT or with eye care. So now in the clinic we have a cutoff. If IOP of 19 or less, we don't put the baby to sleep. Of course you examine the anterior segment, refraction, the axial length, all of those parameters you're looking at. But if you're just for an IOP cutoff, that is what we take. Above that, we definitely take them up for an EUA and then cross-check.
May I ask you regarding your experience? Actually, I have eye care, but I don't have it for the children because I have eye care when sitting in the standing position, not with the current position. usually for these patients, I measure their pressure with the tonometer. Do you think it makes a difference?
I mean, in the clinic, the tone becomes very difficult for a baby because you definitely have to, yeah. In the operating room, I think it's okay.
Well, it's just a question. If the eye care and the Perkins give you different numbers, which is real? And I think we've just got this indoctrinated thing in us that, oh, applanation tonometry is the gold standard, but we don't know, and there's no evidence. And I would say if one is high and the other isn't, you should still be suspicious that it could be high. That's my take.
The cornea here is abnormal, not only for the thickness, but also for the hysteresis. That's why different measures, other data like the optic nerve can help.
We're coming to that straight away. So we're investigating that child, we're doing a B scan to check the posterior segment morphology, and moving on to the very important fact that in childhood glaucoma, the intraocular pressure is not the primary decisive marker, but it is the optic nerve. So our question is, do you assess optic nerve cupping with the B scan, whether if you're doing the B scan yourself or your optician optometrist that is doing the B scan? The question is, do we rely on optic nerve assessment using the B scan in cases where the cornea is cloudy and we could not see the posterior segment? So what does the panel think about that?
I only know one person in Egypt who measures the cup disc ratio.
I know the same person.
We all know this great thing. Professor Nader Bayomi, exceptional in this. So she gives me the reading, but actually I don't refer routinely. So I don't see the fundus, but I will follow up. In the following week, the cornea is probably clearer, and I will see the post-operative 1 week cup disc ratio, which hopefully will even reduce at 1 month post-operatively and so on. But yes, if few people probably on earth, they can measure the cup disc ratio accurately and in pediatric glaucoma.
I usually use the indirect subscope. The light is very strong and in a very good percentage of these kids, I can see the optic disc. If it is opaque cornea, it will be difficult. If it is edematous cornea, I can see the optic disc through dilated pupil. The cupping can be clear for me in a good percentage of cases. That's why I prefer to examine the kid in a separate section. After the surgery, because I dilate him very well, and after the examination, I will discuss everything in details for the parents before taking the decision of surgery.
The literature agrees somewhat that the sensitivity for assessing the optic nerve cupping with the B scan is somewhat low. We use, of course, the A scan to assess the active length, and let's skip this question, that's not an issue. Just the question of the UBM, just a second question. If we're going to assess the anterior segment with UBM, would we use the water bath in which we apply the cup directly to the child's eye, or do we use that clear scan attachment that attaches the water bath to the probe directly? It won't make much of a difference, but as we can see here, where we practice, the lower lid tends to come into view if we're using the water bath directly. So would you agree with me that if we have that clear scan attachment, would be a better advantage than the water bath itself, or does it make much of a difference? Usually have.
So we have two different dimensions of the water bath, and I prefer to use with the water bath because you get much better details, especially with the aid of the ciliary body and things like that. We're dealing with an anterior segment dysgenesis. The soft water balloon that is there, that is easier to use, but you get indentation on the cornea, and if there is edema, the details are not very clear. So I prefer to use the water bath, but it's possible to do it even in the clinic. So we don't do, it's possible, the majority of the children we do it in the clinic without anesthesia itself, a topical anesthetic, and of course the lid speculum becomes very important in them, atraumatic lid speculum, and then with the water bath we get the UVM. And that is critical for every child with a hazy cornea.
And the small size cup would do. Small size
Yes,
glaucoma too with
yes,
speculum.
yes, yes.
Thank you. So, now the question would be, how would we confirm the diagnosis when the optic nerve might not be visible? As Professor pointed out that if the cornea is edematous, we may be able using the indirect ophthalmoscope to check the optic nerve. But in some cases, when the cornea is scarred, the optic nerve is not visible. So would we rely on, for example, the above the reported normal values of the intraocular pressure, the cornea length, the axial length, or would we wait for progression over measured baseline values? That is, would we wait and follow up that child, or would a single, let's say, cross-sectional examination would do for taking the decision management? What would our panel think about that? And if you would follow up, what would be the frequency of follow-up of these children to take the decision?
One very quick comment. We have some real criteria we have established for treatment, and this is one of the few cases which we diagnose only by the cornea. So unlike the CGRN classification, you have always to have two factors. But this is one case. If I have a megalocornea together with corneal edema, a megalocornea above 11, below 1 year, and more than 11 by the second year, we operate only based on corneal findings. So this is one case. So just like this, even the pressure is low and I cannot see the optics. This is a comment we have.
This takes us to another more important question that I would be interested to ask the panel about. If the diagnosis is one of a secondary glaucoma, secondary childhood glaucoma, not a primary childhood glaucoma, like for example, this eye of this child, would you operate for glaucoma, and which procedure would you choose, and especially if the B-scan means this option? I want to go actually to this second question, which is what represents to our panelists an inoperable eye, if this exists actually. Because actually, to be honest, this eye is actually the eye of a child that has been operated elsewhere. So this child has actually undergone glaucoma surgery. So the question is, for secondary childhood glaucoma, would you operate for any secondary childhood glaucoma? Which procedure would you choose? And do you have such a classification as an eye that is inoperable for glaucoma? Dr. Suresh, what do you think about that?
Yes, we do come across these cases, and this patient I wouldn't operate. I think we need to understand what are we trying to restore. Are we trying to restore the anatomy? Are we trying to help to improve the vision? And especially if this is one eye of a patient and the contralateral eye is seeing very well, I wouldn't touch this eye. Because even with maximum amount of, let's say you want to do an anterior segment reconstruction, even if the posterior segment was completely normal, let's say the B-scan is normal for this eye, even if you go ahead and say, I will do an anterior segment reconstruction, what are we trying to achieve? I think we need to be very, very clear about the aims and objectives.
These are the anterior segment, these are the UBMs, images of these, the child.
Yeah. If suppose the contralateral eye was, let's say in anterior segment distances, you have a lot of asymmetry. Other eye, the eye is not developed at all. You have enough thermos in one eye, and the only seeing eye, or rather the only eye, is this. Then there, maybe I will try and understand what the underlying cause is. Often, this kind of a presentation happens when you have a pupillary block that develops in utero, and then they have a huge eye. In a situation like that, I may want to do a minimal manipulation to understand if there's a pupillary block. Can I make a pupilloplasty or things like that and see, give a chance that I can try and help this eye. Otherwise, I wouldn't be very aggressive.
Let me tell you something. Because dealing with these cases, glaucoma, this glaucoma is totally different from other glaucoma. So when we diagnose even when we diagnose glaucoma in child, we don't follow the same criteria as we follow from other glaucoma. Maybe with the cornea in diameter, with the corneal basis, with the axial length measurement, maybe it's enough for me to take a decision. I don't need to see the fundus, I don't need even to choose the picture correctly and perfectly. So this is also the same advice when we deal between primary congenital glaucoma and the secondary childhood glaucoma. Yeah, because the strategy is a protocol for treating primary congenital glaucoma is totally different. I like what Serge said, what we need to do for this child, what we need to restore vision, We will try to minimize the pressure, or just we try to keep the eye in good shape. That's all. So we have to think about this child every time. When we have a case like this, with anterior segment dysgenesis, everything is disturbed. Yeah, I don't think that you are able to maybe just getting the eyes quiet, the pressure is controlled, maybe with something low or something like that. Not enough.
Let's pick up that, ask our finishing questions. About medical treatment, just as a reminder to the audience, we're dealing with a child that presents with a cloudy cornea in the first month of life or the first few days. What class of drug would you prescribe? Now, our panelists have told us that they do prescribe medical treatment until you go for surgery. What class of drug would you prescribe for such a child that is just a few days old? Do you have a specific recommendation?
The routine easy is carbonic topical and beta blocker together. Beta blocker is, by the way, effective in children, and the very important point, of course, is absolutely avoid alpha agonists. After that, you add, the prostaglandins, we are not sure about its effects in infants, actually, in our experience.
Even beta blockers, sir? That's the question. Beta blockers for just a very few days old children.
Yes, as long as there is no breathing problems, yes, actually, up to our knowledge with our cases.
Okay. You arrange with the pediatrician?
We make sure, about there is no chest problem, either with the family, with the history, and we watch for some time, and we can warn the parents if there is any respiratory symptoms. But it is a normal child with no asthmatic suspicion whatsoever. Beta blockers, I believe.
Suresh, you use different class of drugs. Which type of drug do you prescribe until you go for surgery?
Often it is only topical dorzolamide and beta blocker only if for medical reason if the baby is not getting a fitness for surgery, let's say in the next 1 month. So there are some situations like that where you have to wait, or there is a nasolateral duct obstruction and then requires a syringing and probing, and you have to wait a couple of weeks before you take it up for an intraocular surgery. In situations like that, then I give 2 drugs, otherwise usually just topical dorzolamide.
Dorzolamide, so topical carbonic anhydrase inhibitor is the safest. Okay. So the take-home message is, for secondary glaucoma, make sure that you define the target of the treatment. Is it just to bring down the pressure, to restore the anatomical integrity of the eye, or to provide vision? For primary glaucoma that present in the first month of life, medical treatment has to be weighed against safety. We're given the options of beta blockers and carbonic anhydrase inhibitors. So I guess for the sake of time, this brings us to conclude, Dr. Hazem, okay? Conclude the session, okay? So,
thank you very much.
Panelists have any comment?
Professor Nader always has the best panel discussion in ours. So
I'm honored.
we always enjoy your challenges.
I'm honored to be
Thank you
with
very
you.
much.
Thank you. Okay.
And,
Excuse us.
So actually we have the coming hour is very rich in the conference, so we have 3 sessions. The main session, the main